Hi, everyone, and happy Ides of March Eve. I'm David Glazer, and we're going to talk today about compliance plans and how you can use them to try to stay out of trouble. Very few announcements as usual, just a couple of quickies. So first off, it's the noon hour. The internet sometimes gets slow. If I start to break up or sound like I have been slowed down, you can always use the dial-in number that Robert is sending out in the chat box in the bottom right of the screen. That's also where you can ask questions if you want to at any point during the course of the webinar. And the only other announcement is our next webinar is going to be on April 11th, and the topic is going to be physician supervision. It's kind of going to be a mismatch that should apply to both hospitals and clinics, and so it'll cover, physician supervision requirements for diagnostic tests, physician order requirements for various services. What level of physician order do you need, what kind of signature requirements, and the like. So that will be the same time on April 11th. All right. Well, let's dive in. First, an apology. For those of you who have heard me before, I don't have any new jokes. These are going to be the old jokes. And for those of you who haven't heard me before, I don't have any good jokes. But with that in mind, a cartoon that a friend of mine sent me some years ago, which I'm fond of. This could be Martha Stewart or Bill Gates sitting around doing some planning, and they're going from A to B to C, and you can either wind up at top, like Bill Gates, or at the bottom, like Martha Stewart. And stay with me now, people, because in step C, things get a bit delicate. And the question in a lot of what we do in healthcare is, are you going to make it big, or are you going to make it on TV? And compliance is really all about trying to avoid the bottom. In many ways, the basic principle of compliance is simple. The system should be fair. And it's easy to lose sight of that because there are so many kind of conflicting goals right now in the healthcare world. So really, the first part of compliance education to me is the notion that any healthcare organization, whether it's a clinic, a hospital, or a device company, should be seeking reimbursement for something that they've actually provided. That's stating the obvious. If you billed for something and you didn't do it, you should refund it. That's also kind of stating the obvious. A part that gets a little bit more lost is that in a situation where work has really been provided, a refund should only be required where there's a clear rule that prohibits the service that was provided. And then a refund might be necessary. I would note, however, that there should be a distinction between rules and policies. All kinds of organizations will create policies that require a refund. And this is really where us lawyers get to earn our money, because our job is to help sort through what might be aspirational from what's required. And I think one of the challenges in a compliance process is making sure that that being compliant doesn't mean being a patsy. You can be compliant without doing everything that the government or an insurance company says that you need to do. If you work on the basic principle of being fair, you can have an effective compliance plan and still be assertive. A caveat for all compliance stuff, not all payers are created equally, and that makes regulatory questions challenging and problematic. A rule for one payer may not be true for others, and that can vary. Medicare may have different rules from Medicaid, in fact it does, and private insurers will have different rules from Medicare and from one another. And so for private insurers, unless you have a contract with the insurer, first of all, then it's almost anything goes. Anything that's a reasonable industry norm is okay. If you do have a contract with the insurer, you need to look at that. And then also you need to look at whatever other materials they provide you, because the odds are that contract will send you to some online manual or other piece of information. But it's important to understand that while it's useful to have standardized rules, and it's much more easy to implement standardized rules, they're not a requirement. You don't need to treat Medicare the same way you treat a Blue Cross Blue Shield product. They're different, and you can act differently. So one of the biggest challenges for everyone in the compliance process is separating fact from fiction. Conventional wisdom, something which I think might often be called the knee-jerk reaction, can be wrong. People have incentives to make assumptions. Health plans can characterize stuff as overpayments because they want the money back. Us lawyers can have incentives to characterize stuff because it's too hard, and so we want to just say no. There are all kinds of reasons that people make assumptions, And sometimes the approach to legal research is to call up the government and ask, hey, do we need to refund this money? And they obviously have an incentive to answer that question with a yes. Everyone should be a cynical consumer of all advice, whether it be from their lawyer or an outsider, and you want to question authority. You want to ask whether something's a requirement or a guideline. For Medicare, that's easier because there's a very clear hierarchy of authority. There's the law, below that the regulations, below that the manuals. Much easier in some ways to figure out the hierarchy of Medicare than the hierarchy of a private insurer, or even Medicaid, because in most states, Medicaid rules are much harder to find. If someone's telling you something's a rule, ask to get a copy of it in writing. And it's reasonable to expect lawyers to explain both what they're telling you and what the position of the other side is. An important part of all kind of compliance questions, someone might find a rule that says we're not allowed to do X. But just because the rule was written doesn't mean that the rule is valid. And so that's another place where us lawyers earn our keep, is figuring out whether the rule was properly promulgated. Just because someone sounds smart doesn't mean they know what they're talking about. And the best illustration of this is the two scientists or explorers walking into the cave. Relax, Worthington, as the warm, moist air in the jungle enters the cave. The cool, denser air inside forces it to rise, resulting in turbulence that sounds not unlike heavy breathing. That sounds super authoritative until you look at the garbage can full of bones. Okay, the environment in healthcare is going to continue to be one where shakedowns are common. For a variety of reasons, the government is going to characterize routine health activities as fraud, and one of the biggies is it avoids answering questions like, do we ration care? And so these shakedowns are going to continue, and that leads to a few caveats. One, if you're doing something and you hear it's wrong, don't take comfort in the fact that everyone else is doing it, because that's exactly the sort of stuff the government tends to focus on for future enforcement. Or don't take comfort in the fact that the rule seems dumb, because I've seen a number of examples of dumb rules being enforced. A perhaps more frustrating problem is that I've seen a number of examples of things that aren't rules being enforced. And that's where us lawyers earn our keep again. And it's important to keep in mind that patients right now are being bombarded with call and turn in your provider when they commit fraud. That's okay, but you want to take the time to educate them about billing, because you're going to do stuff that is, quote, proper, and patients are going to think it's fraud. You know, you bill under the name of the physician who's supervising an incident to service. The patient won't have seen that doctor, and they're going to think you're committing fraud. And it's problematic and time-consuming, but the time you spend educating patients can help keep you out of trouble. So a compliance plan, the origin of the compliance plan are federal sentencing guidelines. So back in the 80s, Congress passed the sentencing guidelines that said if a corporation takes the following steps and the corporation is ultimately convicted of a crime, the penalty the corporation pays will be lower if they have in place an effective compliance plan. Now, obviously, you're hoping to never be convicted of a crime. So in some ways, what the 7 elements of a compliance plan are, and we'll talk about them in a minute, aren't entirely important. Really, ultimately, the test of a compliance plan is, in my mind, something very different. A Crown Victoria pulls up at one of your employees' homes at 7 o'clock on a Thursday night, and a guy or gal with short hair and an attitude knocks on the door. You know, the person thinks it's the pizza delivery man. They walk out and find out it's an FBI or an OIG agent, and therefore, you know, amongst their questions to the staffer is, what's your organization done to comply with the law? And so really, if you think about it on a global level, it's more about creating a culture, a sense that people feel comfortable talking about things. You want people to feel like they can vent internally. You want them to feel like they know how to vent internally, whether it's using a hotline or using email. If they don't feel comfortable walking into someone's office, they know how to send an anonymous email or an anonymous note. And that's really, ultimately, the measure of a compliance plan. It's all about attitude. There are many reasons I don't worry about policies, and we'll talk about that in a bit. Instead, I focus on getting people to understand a couple of responsibilities. employees have an obligation to make sure that they know what they don't know. Don't assume. If your job is to try to figure out the rules, don't guess at the rules. If you don't know, ask. And that in turn, the organization has a duty that if you ask a question, you can expect an answer. And that last one is an important and often challenging thing, because how you communicate to an employee who raises a concern can raise all kinds of issues, including if you ask your lawyer, is this okay? And the lawyer says, yes, it is. When you communicate back to the employee who asked the question, have you just waived the attorney-client privilege? The answer to that isn't entirely clear. But from a practical level, you may wind up choosing to communicate the information back because you want to feel like the people in your organization know what's going on. So, as part of the compliance process, this know what you don't know is important. You need to do a lot of reading and education. You need to look at the bulletins that Medicare puts out. You need to look at government websites. Trade associations can be a good source of information and also a good source of misinformation. Magazines can be a great source of information and also a great source of misinformation. And of course, the OIG work plan. But one of the important principles of any compliance process is the rules are complicated, and the only way you're going to you're going to screw up. That's, I think, a given. But to catch as many of the screw-ups as you can, you have to cast a broad net and look for new sources of information, and then just read those cynically. Don't assume that something that's in the even in a Medicare manual is right, but check it out. Okay, so here are what the law defines as the 7 elements of an effective compliance plan. And I'm going to talk about each of them in turn. So this is really just here almost as an organizational slide. If you want to see in one place, here's what you need to have an effective compliance plan. So the first thing you need are policies and procedures. And I think they're one of the most challenging things. I personally am not a fan of having many policies. And the reason is, I don't know if it's just that I'm incompetent, but I can't write a good policy. I can't think of all of the ways things can go wrong. And let me give you a good real-world example. Here's an easy policy, you would think. Anytime someone intentionally misrepresents a fact, we'll fire them. I mean, that seems fairly straightforward to me. I would have been cool with that policy. Until I had a clinic where a doctor had a patient with a very unusual medical condition. They called the insurance plan to get coverage. And the insurance plan said, we don't cover it in this situation, but here's what we think you should do. Why don't you just say the patient has this other condition and we'll cover it? Now, that sounds fairly improper and fairly fraudulent, but it was an instruction coming from the insurance company. Perhaps the physician should have disregarded the instruction, but there was no doubt that this in fact had occurred. Should that physician be fired? It's not that clear to me. And it's a great illustration of how writing in absolutes is difficult and can come back to bite you. The other thing is the government loves to take violations of your policy and try to recharacterize those as violations of the law. And as a result, I'm not a fan of having that many policies. You might think we'll have an aspirational policy, and even if it goes beyond the law, if we don't make it, we don't make it. Well, I've seen too many investigations where the government tries to say, you didn't meet your own policy. They shouldn't be able to do that, and I think you have valid defenses. But because of that, I try to keep policies to a minimum. The second thing that you have to do as an effective compliance plan is avoid giving responsibility to people with a propensity to engage in illegal activities, which is just a great phrase. I hope you don't hang out with people with a propensity to engage in illegal activities. But making that practical, you want to make certain that no one who's involved in your care team, and this applies whether you're in a medical device company or a hospital or a clinic, that you don't have people who've been excluded from Medicare and Medicaid. And I think you want to know, frankly, I'd go all the way through the organization. If you're in a clinic, the fact that a janitor has been excluded from Medicare or Medicaid is irrelevant. In a hospital, it's not as clear because those people might wind up on the cost report. But I would run the names of everyone you've got as an employee through the Medicare, Medicaid exclusion list to figure out who's there. One of the questions is how often you need to recheck. I recently heard something, I'm trying to remember the source of this, where they were claiming you have to check every 6 months. In fact, I think that might have been in some of the health reform stuff. But there isn't a clear requirement on that, at least that I'm aware of. I am a fan of checking at least annually. I think checking more frequently than annually is a lot of work. Maybe you could go to every 6 months. I certainly would not be checking on a monthly basis. You want to check when you hire someone and then check periodically because people can get excluded. I've had that happen with clients. Also, you want to use compliance as a factor in your employee evaluations, and you're doing it in two different ways, making sure that the employee is aware that they need to be acting in a compliant fashion, but then also asking them for their thoughts on whether the organization itself is compliant. So you want to get feedback from them, and you want to make it clear that if an employee acts inappropriately, they'll face potential discipline. The last point on this topic is listen out there. We're George and Harriet Miller. We just dropped in on the Pigs for Coffee. We're coming out, and we don't want trouble. Well, the truth is, if you hang out with the three little pigs and the big bad wolf comes over, you're going to get judged by the company you keep. And if you have people in the organization who have a reputation for flouting authority or flouting the rules, the government will seize on that. And many of the compliance issues that come up come from people that everyone sort of rolls their eyes at because everyone knows they push the envelope. Well, if you've tolerated the envelope pushing for a long time, you're not going to be able to run from that when it's time to pay the piper. Another element that is required for an effective compliance plan is training. And that kind of goes without saying, but training is broad. Obviously, this webinar is an example of training. Training is really anything that educates you. It can be attending seminars, it can be reading materials. And so I think one of the challenges for organizations is tracking the sort of self-education that any ambitious person in an organization does. That counts as compliance training. I mean, if a physician is taking stuff to learn how to code, that's totally training and something that can count towards your compliance process. And you need a mechanism to know what each of your little individual coders, if the CFO of the hospital attends this webinar, that counts. How are you going to track that? Part of the training is educating people internally that there's a difference between fraud and mistakes. If you go to a lot of webinars right now, they'll talk about healthcare fraud. And the truth of the matter is there isn't a lot of healthcare fraud. There are a lot of healthcare mistakes. Part of the training is training people not to take risks for reimbursement and to recognize that if a supervisor demands that they do something that's inappropriate, they know what to do. And there are so many stories I could tell at this point, but one of the ones I like to use, it's an old one. One of the very first times I ever had a compliance issue, coders, and this happened to be in a cardiology practice, thought Medicare paid poorly. And so every time a physician billed a 99214, they made it a 99215. If they billed a 99213, they made it a 99214. If they billed a 99215, I guess they invented a 99216 because they thought the physicians were getting basically cheated, so they wanted to help them out. It was well-intentioned on one level, but ultimately, after we scraped the clinic administrator off the ceiling and tried to figure out what to do, we called Medicare to refund the money, and Medicare at this point, this was in the early 1990s, didn't know what to do with the money. They said, oh, just keep it. That wouldn't happen today, but the lesson from that episode is an important one because there were employees who thought they were helping the organization by taking risks. And you want employees to understand that we want to be coding appropriately, not undercoding. We don't want to leave money on the table, and we don't want to be paid too much. It's also important, though, for employees to know how they can address problems, and we'll come to that one in a minute. In the current healthcare environment, it's okay to be worried, but sometimes worry turns into this. The fuel light's on, Frank, we're all going to die, we're all going to die. Wait, my mistake. That's the intercom light. How do you have employees thinking that they don't all need to quit and go into into the candy business to avoid healthcare? And I think part of the compliance process is saying, look, you aren't going to go to jail. And I'm going to jump ahead to the last point on this slide for a moment and say, employees often will hear things like they need coding insurance, and a lot of staff are convinced they're going to jail. The truth of the matter is, the people who go to jail in the event of, at first, it's relatively unusual. Money gets paid back a lot. Not a lot of people go to prison, but the people who go to prison are the people who profit from improper activities. And oddly, to me, an important part of compliance is calming people down and helping your coders know they're not going to jail and know they don't need coding insurance, because as long as they're acting in good faith and believe that the acts they take are both legal and consistent with their corporate instructions, in almost every state in the country, they're required by law to be indemnified by the corporation. In the handful of states that don't require that kind of indemnification, if it's permitted, I would encourage the organization to extend it, and so that they can tell employees, look, we've got your back. You know, if we as an organization are investigated, we'll cover your legal fees. You aren't going to get in trouble for a mistake the organization makes. That alone can greatly reduce the risk that one of your employees becomes a whistleblower, because often whistleblowers are created out of a belief that the employee is going to pay the price for what they perceive to be an improper action. So one question organizations have to wrestle with, that, I mean, hopefully all of you guys have a compliance plan at this point, but how broad should it be? Is this just for billing, or does it cover other things? And I am a big fan of keeping it broad. You know, it's true that the sentencing guidelines only talk about criminal violations, but I like to use the sage words of my colleague Steve Beck. You don't want to be on TV. I think your reputation is broader, and it basically boils down to this. This is my favorite Gary Larson cartoon of all time. So we've got cat chasing, garden digging, and garbage dumping, all of them sort of irregular. Now, if you'd examine the chart, you will notice that, well, it seems that Mr. Sparky has found something more engrossing than this meeting. And if you look at Mr. Sparky in the lower left corner, it looks like he's sniffing his crotch. And using a crotch-sniffing dog in a presentation isn't something you get to do every day, but I do it here because I think if you get in trouble for violating a sex harassment law or for, dumping medical waste in the backyard, any of those things will get you on TV. I think you want employees to feel comfortable raising any of them internally. And so I would encourage everyone to raise any concern they've got. Will this result in you getting a bunch of HR concerns brought up through the compliance process? Yes. But I think that's a price worth paying. The next element in a compliance plan is you have to monitor and, quote, audit compliance. I put audit in quotes for a reason. I don't like to use the word audit. I'm much more partial to using the word review, because the government seizes on the word audit and says that you need to, that if you've done an audit and you find anything improper, you need to refund the money. And we'll spend just a couple of seconds going through a few slides talking about how you can have situations where you identify potential problems that are in fact not overpayments requiring money to be returned. So I try to avoid the word audit. Instead, do reviews. Now, one of the questions you have to ask, are people going to listen more to internal or external reviews? A benefit of an internal review is that people know the person doing it, and that can be a positive or it can be a negative. Sometimes there's the pro from Dover syndrome, where only advice from outsiders is taken seriously. And if your organization is like that, you better have external reviews done. If people trust internal reviews, I'm a big fan of keeping the costs down and doing stuff internally, although I do encourage organizations to have periodic external reviews to review the reviewer to make sure your internal people are neither too conservative nor too liberal. Whenever you're doing reviews, you have to make sure that all types of services get reviewed. And I'm going to use a physician example here. It's easy to review stuff that happens in the clinic because those are easily accessible. So we had one clinic that had a very nice, robust compliance plan where they looked at stuff that was done in the clinic, but they didn't pull any of the hospital charts. And so they missed the situation where a physician had gone to see a patient in the hospital. The patient wasn't there, and the physician wrote a note, pinned it to the pillow, and said, "Sorry, I missed you. I'll catch you next time," and then billed a level 2 hospital visit for that fine encounter. Which obviously you can't bill for something where you don't see, or not obviously, but you can't bill for someone who doesn't see the patient. And that sort of thing gets missed if you don't look at all types of services. If you're in a hospital, you got to make sure you're looking at all of your locations and all of your service lines. It's a pain, but it has to happen. I don't worry much about statistical validity was a part of these reviews. You're just looking to try to identify problems, and so don't hire a statistician, just look. When you do these reviews, you've got to be careful about your wording, because it's really easy for people to say things, oh God, we just did something that was fraudulent. And any statement like that is an easy admission. And so part of the review process is training people on how to use the right words. You use words like preferable or would be better characterized. I think all of those things are better than characterizing something as fraudulent or even improper. We would be more comfortable defending this level is a much better wording and more likely to avoid being characterized as an admission. You got to make sure employees, everyone wants to feel comfortable reporting their concerns. And I think everyone worries about being the squeaky wheel. It's a legitimate worry. And so people have to understand that both organizational policy and the law prohibit retaliation for people who bring legitimate compliance concerns to light. I encourage all hospitals, clinics, and device companies to have, both a formal and an informal structure. And here's an interesting story. Worked with a fairly large organization that had a compliance issue, and we had to meet with the OIG to convince them we had an effective compliance plan. And they said, so do people use your hotline? And the answer was no, something of which the organization was really proud because they had an open door policy and they felt like people came in and raised concerns. The person from the OIG viewed this as proof that the organization did not have an effective compliance plan because in their mind, if people aren't using the hotline on a regular basis, obviously they're not bringing concerns to light. It was a beautiful illustration of the difference in perception. So you want to have both formal and informal processes. I don't agree with the OIG that the fact that your hotline isn't being used is proof of wrongdoing, but it means you're going to have to be able to show that your informal process is working. So you need to be able to demonstrate every time someone comes in and reports something, or if not every time, enough of them to be able to show that things get reported and get fixed. Explain to employees that if they're worried about retaliation, they can, get a Hotmail or a Gmail account and send in an anonymous email. The process I'm most fond of encouraging is tell people talk to your supervisor first. If you don't feel comfortable talking to your supervisor, or if they don't get back to you, go to the compliance officer. If you don't feel comfortable going to the compliance officer, if they don't go back to you, here's contact information for our corporate attorney, whether that's an internal or an external position, and tell them that they can use all three. Give them as many points of contact as possible. Personally, I have not been called directly by an employee in an organization, but I've had my number given out to lots of them because I think as a last resort, you'd rather they call you or have them call your outside counsel than call the OIG hotline. As an aside, I did have saw a lawyer once who developed a compliance plan that gave the OIG hotline in their compliance materials, an idea which I would strongly discourage. You need to encourage employees. Everyone should know if they report a concern and don't get a response, report again. Things fall through the cracks, and some of the worst compliance problems or the most frustrating are ones created where a mid-level manager knew about the problem and didn't fix it. And I've seen some seven-figure problems, multi-million-dollar issues where, in a hospital, a nurse manager knew about a problem, but no one above the nurse manager did, and no employee felt comfortable going around the nurse manager. I've got a form that's really short, and I recommend you use as a semi-annual or even quarterly certification. If you send me an email, I will send you the form right after this presentation. It's super short, and it basically just asks, are you aware of any compliance issues? And if you gather those on a regular basis, it becomes great evidence, A, that you're asking, and B, when you have a situation where someone says, I've got this compliance concern, I've raised it over the last 10 years and no one did anything, this is a great tool of saying, look, this person has not in fact raised this issue time and time again. So actually, if you get nothing else out of this webinar but using that certification process, I think that alone might be worth it. As part of an exit interview, make sure people are being asked about compliance, because people walking out the door are often more likely to be candid about things. The next element you need of a compliance plan is addressed by the "he's using blanks, pass it on." You have to have some sort of mechanism for enforcement through discipline. And this is a tough one for me because I actually am a bit of a softie on this one. I think people are going to make mistakes, and I think some of the best employees are people who have made mistakes and learned from them. I don't think you want to fire everyone who goofs, but you don't have to. Discipline doesn't mean firing. Discipline means educating people, and in particular people who make the same mistake more than once. And this is one where I'm not as much a softie. In fact, according to my wife, I'm a field marshal. At least that's according to the psychological test that she gave me as she was going through her psychology program. Repetition of error is something that doesn't sit well with me, and it doesn't sit well with the government. So the bottom line is you have to appropriately discipline anyone who violates the law or a rule, and people who fail to detect an offense. And that's an interesting one. If you've got a supervisor who should have figured out what was going on, you should be disciplining that supervisor for failure to detect the offense. Now, appropriate discipline, like I said, it doesn't mean fire, it doesn't mean suspend, it might be coach, but you got to do something. It all comes down to, late again, this had better be good. If you look at Mr. Bear here, and this is sexist of me, but I'm assuming that it's Mr. Bear who got tagged. If this is the first time Mr. Bear got tagged, appropriate discipline is saying, don't do this again. If this is the 7th time Mr. Bear has been tagged, then I think something more substantive is probably required. The bottom line is think of a process like peer review. It's educational. It's figuring out some kind of progressive penalty to make a message. On the coding front, I know clinics have used Saturday school for physicians who don't code properly. In the hospital setting, if you've got a coder who just doesn't seem to learn stuff very well, you come up with financial incentive program. A quick aside, this isn't directly related to compliance, but in a compliance process, you often have to get advice, whether that's advice from a lawyer or advice from the government. When you're getting that advice, don't forget that you have to disclose all relevant facts. And this is an interesting problem because in order to know what fact is relevant, you almost have to know the law. And so this gets cyclical. And I'm going to use an example of a specialty hospital I was working with, and they were asking if they could operate or put up an MRI. So the specialty hospital referred to themselves as a surgery center. And so they called and asked me, David, can we put in an MRI? And the answer was different if they were a surgery center than if they were a specialty hospital. And it was only because I wound up being in a loquacious mood, difficult to believe, and I was explaining to them, well, this would have worked if you were rural, but you're urban. It would work if you were in Puerto Rico, and it would work if you're a hospital. And the administrator I was talking to said, actually, we are a hospital. And suddenly we realized that something that I was going to say was improper proved to be proper. Well, that could work either way. But the bottom line is, when getting advice, you have to disclose lots of facts, and to know what all the facts are, you have to know what the relevant law is, and that means you really need to be working with someone you trust. And so part of this is don't ask the government for advice until you figure out on your own whether something works or doesn't work. If you have an overpayment, you're going to have to go to the government and self-report. I just don't want the government to be part of the investigative process. If you ever do ask the government for advice, make sure you confirm it in writing. And since it's hard to get the government to write you a letter or to get an insurance company to write you a letter, write them a letter, send it via certified mail, and you're in great shape. Dear so-and-so, on such and such a date, you told me X. I just want to confirm that. If I'm wrong, let me know. And then if you don't ever hear from them, you're good to go. When you're asking the advice, avoid the dorsal fin problem. Well, somehow they knew we were, our dorsal fins are sticking out. I wonder how many times that's screwed things up. So if you think you've done something wrong, don't go to the government until you know you've done it wrong. I think you want to go to the government when you're saying, look, here's what we did and here's how we're going to fix it. The only time I'm a fan of asking the government questions before I go, investigate thoroughly on my own is if it's something that we haven't yet started. If you haven't started it yet, I think it's okay to ask the government, do you think this is okay? But if you've been doing it for a while, you have to make your own decision as to whether it's kosher. All right. The next part of this is I want to go through a few what-ifs, actual compliance scenarios and things in hospitals and clinics that people need to worry about. So this one is anyone that, whether it's a hospital or a clinic that has physicians. You do an internal audit and find this. And so we've got Dr. A, 13% are undercoded, 76% are right, and 11% are overcoded. Dr. A is not doing too poorly, although you'd like to see that number a little higher. Dr. B is leaving a lot of money on the table and is wrong 70% of the time. We've got Dr. C who's overcoding 35% of the time. That's trouble. Dr. D, wrong 81% of the time. And then Dr. E, the president of the group, using the most sophisticated coding technique known to man, random code allocation. And just comes up basically a third, not unlike the Alabama and Mississippi primaries from yesterday. So if you get results like this, what do? Well, here's the first thing. I think you don't know yet. There are facts you're going to need to look at and stuff like that. But what you need to do is have people prepared to address a whole bunch of issues here. One, and I'm not going to spend any time on this today because we've covered this in other talks. And if you want to hear this in more detail, send me an email and I'll get you hooked up with one of those talks. But remember that if it isn't written, it wasn't done is not the law. It's great advice, but not the law. To back that up, there are a bunch of slides right here, and I'm going to skip through those, but they're in your materials, that substantively say if you really do a service and you're a physician, you can bill for that service even if the documentation isn't there, with a couple of asterisks. And one of the asterisks is if it's anesthesia, there's kind of an exception for certain anesthesia, and there's also an exception for teaching physician services involving a resident. So let's put those two asterisks aside. Otherwise, for Medicare, the lack of documentation doesn't create an overpayment. There's a third asterisk, which is Medicaid, and I'm just going to leave that one aside. So here are a bunch of slides. You can review those on your own. And like I said, if this is new to you, send me an email and I'll get you hooked up with stuff. I do want to remind people, though, because I still see this a lot, this slide has two giant mistakes on it. And it's not that 33, 33, and 33 add to 99. It's that don't use the word audit, call them reviews, and try to steer clear of the phrases undercoded and overcoded. I think that they invite trouble. Instead, I prefer that the documentation exceeds the code, or that documentation doesn't support the code, or the documentation does support the code. Any of those phrases more accurately describe what's going on, because the truth of the matter is, if you've got a level 5 service build and the documentation is at a level 3, you don't know whether the doctor did a 5 and only wrote down enough to support a 3, or whether they did a 3 and are truly overcoding it. You can't tell that from the documentation alone. All right, another what if. So one day, a patient who's treated by the very productive president of a physician group calls and complains she's billed for a complete physical, but she never removed any clothes. So what do? And I love this one for a whole bunch of reasons, but really I like it the most because my client, as often is the case, was smarter than me. The client said, well, first thing, this first part of this is obvious. You pull the chart. So you look at the chart, because it's possible you can have a complete physical in 99215 based purely off of counseling time. So you don't have to take off any clothes. But there was, in fact, a complete physical documented in this patient's record. But there was some other information as well. It turns out that when you looked at this physician's appointment book, the doctor worked from 9 to 3 that day, took lunch, and saw 67 patients. 6 of them were billed as 99215s or 205s. And there was documentation for almost all of these. Now, it's interesting because I think when they found a complete physical documented, many organizations would have said, the patient is a crackpot, and closed the books on the thing. And I'm cheating a little bit here because I'm leaving out one kind of important fact, which was the clinic had heard from a receptionist that the receptionist was a little worried about this doctor. It seemed like he was maybe billing for things he wasn't done. And she didn't have lots of details, but she had a little bit of nervousness. And that word got back to the administrator, which is why she pulled the person's calendar and got this additional piece of information. So what looked like a crackpot patient, once we got this additional detail, took on a whole different tone. And it turns out, at the end of the day, I'm fairly sure that the physician was using templates for documentation, and physicals that weren't occurring were getting documented. And as an aside, in the electronic medical record, this is a very real risk. We have the risk of insufficient documentation, but we also have the risk of documentation existing for a service that wasn't done. So not only does it not, oh God, I'm going to just mangle a sentence, but it not being written doesn't mean it was done, but it being written doesn't mean it was done. Okay, that was too awful of a sentence. All right, if you do reviews, do you quantify exposure? You're a hospital. You look at your dialysis unit, and you've got some questions about how some of the services were provided. Do you quantify it? Well, as soon as you quantify it, the government may use that number against you, and so there's a real risk in quantifying it. If you don't quantify it, it can be difficult to get someone's attention. In the hospital context, it can be more challenging. In this service, in the situation where you're talking about physician encounters, I'm a fan of using language in the next two slides. Just steal it. If you're doing chart reviews, tell people, look, this is a chart review that's not an audit designed to determine whether we've been overpaid or underpaid. It's not statistically a statistically valid sample, but this is what Medicare would do in the first phase of an audit, and so I'll give you some idea of what that letter would look like. So that's easy to do for evaluation and management services. This is a lot harder in certain other contexts. If you're looking at short stays in the hospital setting, it's not as easy to word something like this. And so you have to decide, do I want to quantify this or not? I don't have a clear answer. All right. Not everything is about coding and documentation. So what are the issues that should cause compliance folks the most angst? Well, the number one thing in my mind right now are relationships between drug and device companies and hospitals or doctors. I think that right now is the number one area of attention. Coding problems is a close second. Confidentiality snafus are likely to get you, they're not going to send you to jail, but they're definitely likely to cause major headaches. And then unusual relationships between physicians and hospitals. So those four, I think, cover probably the overwhelming majority of the investigations we work on, and I think they should get the overwhelming majority of compliance attention. So I want to just spend a couple of minutes talking about what folks should worry about. The anti-kickback statute is one of the rare laws that I don't make fun of because it makes sense. It's easy to explain in some level. It's illegal for anyone to either offer, ask for, provide, or accept any payment that's intended to influence referrals under a federal health care program. And the government uses a one-purpose test where they say if there are a whole bunch of reasons for a payment, but one of the reasons is to influence referrals, it's illegal. If you're operationalizing this, it covers any kind of relationships between doctors. So if doctors are, leasing space or equipment or transferring billing rights, there's the potential. Doesn't mean it's illegal, but someone should be thinking about the kickback issues. Any relationships between a hospital and a doctor, someone has to be thinking about, hey, what is the motive for this relationship? If the reason we're doing it is to buy someone off, that's a problem. And someone needs to be thinking about that in each relationship. And then, of course, relationships between pharmaceutical and device companies and either hospitals or doctors. Are all relationships bad? No. Can a drug company pay a doctor to give them advice? Absolutely, but the payment has to be reasonable for the work that's performed, and the work has to be real work. If you're paying for a research study, that's okay. If you're paying for a sham research study, it's not. Something for which a trip to the Super Bowl, which isn't work, is way more problematic than paying someone for a lecture. And it's amazing things you can see in medical records. Professional courtesy is not automatically a problem. But if some doctor writes in or a hospital, actually this was in a hospital record where we saw, don't charge him, he's a good referral source. poof, that all by itself is a violation of the Medicare anti-kickback statute. Discounts are an area that cause a number of questions. I'm not going to try to cover those here because we're tight enough as it is, but our June 2011 webinar on pricing will cover all you need to know about discounts. So if you want to know, just get our June 2011 webinar on pricing. Here's another compliance issue that I think comes up a lot in any medical setting. Someone's at a party, and someone's mom says, "Oh, hey, how is my daughter doing?" Because she, was in the hospital. She got a medical device. And the question is, can, you, the hospital employee, the clinic employee, tell her? And hopefully everyone knows the answer is no. You should say, I really can't talk about that. And that's an area where it feels borderline rude, but I think I don't know if I could count on one hand the HIPAA-like investigations that we've seen on this. And I just want to mention, the reason this is making it into a general compliance slide is I spent 3 days in a Western state helping a client that had the Office of Civil Rights on site for what is, in my mind, a extraordinarily minor HIPAA violation. And actually, an example of that one will be coming up in a moment. But this HIPAA stuff is turning into a giant morass. And so making sure everyone understands, no, you can't tell the neighbor, "Oh, I saw, our other neighbor was in the hospital today." It feels like it's good societal thing and you're just letting someone know about someone being sick, but unless you've got permission from the patient, little things like that can become a headache. So here's the one that got me to the Western state. A nurse comes in and says, "Hey, I think my colleague is faking an illness to get out of work." And so someone says, "Well, let's go check the hospital record to figure out what's up." Poof, that has yielded an investigation that is now 3 years old and still going strong. Don't get me started. All right, Medicaid audits you. And you discover that in part of that Medicaid audit that your documentation doesn't meet the guidelines. Should you worry? Well, and the answer is you might need to worry way more than for Medicare. Now, Medicaid is a weird program because it's a federal program, but state law mostly controls on details like this. And we've got people from literally dozens of states on this webinar, so I can't answer it for each question because the answer varies. Minnesota is less friendly on this point than, say, New York. New York, oddly, is more flexible than Minnesota on this one. But should you worry? Possibly. This is a very important point for all types of organizations. You need to, everyone in the organization needs to understand that you might at any moment get contacted by the federal government. So I was working with an orthopedic physician who got a grand jury subpoena from Atlanta. Now, fortunately, the surgeon didn't look at it very closely, and he thought it was a malpractice subpoena. And so he was like, "David, on that date, I'm busy. Get them to take care of this." It turns out, though, that it was a grand jury subpoena that said in part, "The United States Attorney requests that you do not disclose the existence of this subpoena. Any such disclosure would impede the investigation being conducted and thereby interfere with the enforcement of the law." Imagine what happens if one of your employees sees that, statement on a piece of paper or hears it from an agent who shows up at their door. They're going to think they can't tell the compliance people or the lawyer, in-house or outside counsel about the investigation. Even if you inoculate the patient and inoculate the employee and tell them ahead of time, "Hey, look, you can report contact like this," they're not going to know it. And so, but if you haven't told them in advance, there's no way on earth they will come forward when they get this contact. So it's vitally important that every employee in the organization know that if they get any contact from the federal government, they, as a matter of law, have the right to let the organization's lawyer know, period. And there's no exception to that. Well, the only exception to that are terrorism investigations, and I don't think we have to worry about that one too much. Even if it says you've got to keep it confidential, they can go talk to their lawyer, period. Another area that's getting a lot of attention is off-label use. And this is relevant for both hospitals and doctors because you can't promote the off-label use of a drug or device. So if someone is getting paid to give a speech talking about the off-label use of a drug or device, that's a potentially big deal. Overpayments are going to be a big deal. And actually, I should toss out a proposed rule came out last month to offer details about the requirement that you refund overpayments within 60 days. And a few of our clients are going to try to comment on these rules. And so I think we're going to be doing a group comment split amongst all the folks who want to toss things in. If you're interested in that, let us know. The new rule, one of the things that's in there is in theory, you have to go back 10 years on your voluntary disclosures. So that's a long time. This rule merits comment. But people are going to be looking at stuff like this, and so part of your compliance process has to be making sure people know that once you've identified an overpayment, you have 60 days to refund it. Keep in mind that our opinion is 60 days starts to run after you've quantified the overpayment. So it's not when you have the first hint that a problem has occurred, but as long as once the problem arises, if you diligently try to quantify it, you get 60 days from the date of quantification before you need to refund the money. Another kind of compliance issue that comes up a lot. Patient walks in with a fake ID. They show up in the ED with an ID, and you're darn sure you know that this card is for someone else. Do you have a duty to turn the patient in? And one of the reasons this is an interesting compliance dilemma is that generally speaking, you don't have a duty to turn anyone in for anything. But there are a couple of exceptions to that duty. So one, this refund requirement means that if we know we've been overpaid, we can have a duty to refund the money. That isn't the same as turning someone into the police, but we might have to refund the money. Well, here, if we know that this insurance card is improper, I don't think we have a duty to turn the person in for presenting the card, but we certainly do have a duty not to bill the insurance company, because then I think we're committing an independent act of fraud. And so part of the educational piece here for employees is helping them understand we don't have a duty to turn people in, but we have a clear duty not to participate in any sort of fraudulent activities. For people in either the hospital or in the physician context, Gulf is a scary compliance proposition because it sets up potential antitrust concerns. Whenever two parties agree to not participate in a third-party payer agreement, for example, that's a per se antitrust violation and is a crime. And so as part of the compliance process, there's not a lot of antitrust law anyone wants to go into, but people do want to understand a couple of the basics. You can't fix prices. So you can't agree with another organization about pricing. That doesn't mean you can't know what other people's prices are, but you can't agree. I think hierarchy, and this is probably the bigger your organization, the bigger your trouble. One of the common causes of compliance problems is a manager who tells someone, don't worry about this, and it doesn't get past that manager. So I've talked about that, so I'll mostly move through it, except I think this may be the biggest barrier to having an effective compliance plan is encouraging employees to do an end run around someone who poo-poos stuff. But also to help, there's a corollary thing. Maybe the nurse manager is right to poo-poo it. So it's helping the nurse manager understand how to explain if she's right about the compliance issue, get the employee to feel comfortable with the conclusion that the organization is compliant. I'm just going to skip that one. So do you need to refund all overpayments? And the answer is yes, but the real question is what's an overpayment? And I take the government at its word. Fraud is not a mistake. So you need to refund overpayments, but you don't need to go through the self-disclosure protocol. A couple more myths I'm going to do really quickly before I get to the last part, which is what agents need to know. So people think things like all clinic notes need to be signed. It's good to sign notes. There isn't a clear legal requirement, and a failure to have a signature doesn't mean you need to refund money. It's also useful to know that if there are conditions of participation for your organization, if you're a hospital or an ambulatory surgical center, violating those conditions of participation is bad, but it doesn't mean you need to refund money. It just means, so that's kind of a question for a different webinar, but it's just something I want to note. A thing you hear all the time, you have to bill everyone the same charges. That's, a lot of things that can be put as quick, easy to state phrases are too simplistic. You don't need to treat everyone the same. You don't need to bill everyone the same. And part of the compliance process is helping people understand nuance. They should ask the question and then trust. And then do a little research. Okay, so what do you worry about? You worry about things like anytime you get an overpayment letter or a denial, it's a hint something is amiss. Anytime you get a routine audit, there is no such thing as a routine audit. It's routine only to the auditor. You should be nervous. If you see something that looks like this, that has a little bird in the upper left corner, it should give you pause. And it should give anyone who opens it up pause. This survey went out to organizations back in the mid-90s, so it's pretty old. But I use it because it's so clear. So it's from the Office of Audit Services, and it was what looked like a survey. It asked some basic questions. It was sent to physician groups, and so the first question was, did you order a complete blood count? And the doctors all did. This dealt with automated hemogram indices, this weird blood count process that a lot of doctors don't know too much about. So did the doctor specifically request them? And the answer was always no. And we'll skip to the last one, which is where things get interesting. Did the lab tell you, doctor, that these were automatically included? And all of our doctors that I worked with, they were doctor-owned labs, and I was like, I don't know. They just kind of shrugged their shoulders at this. Did the doctor know that these things were billed separately under the Medicare program? Some did, some didn't. Here was the important question. Were the indices useful to you in the treatment of the Medicare patient? And I worked with about a dozen doctors, and 11 of them would shrug their shoulders and say, I didn't even know how to read these things. So they would say, no, they weren't useful to the treatment of the Medicare patient. The question is, did all of these doctors just admit to submitting false claims to the Medicare program? I can make a legal argument that the answer is no. And my legal argument is that this question is asked in hindsight. In retrospect, were the indices useful? Not when you ordered them, did you expect them to be useful? But this, quote, survey, unquote, just set up a potential false claims investigation. And in some of the organizations I worked with, a receptionist opens the mail, and she took care of this survey because her job was to help doctors. In some instances, the receptionist would take it to the doctor who was embarrassed by the thing and sent it and didn't show it to another person. Sometimes it went to an administrator, and the administrator doesn't want to get a lawyer involved because that's expensive. And you're going, David, how can you know about all of those if no one called you? And the reason is I started using this example in speeches, and every time I used the example, someone would come and say to me, oh, was that a big deal? Well, much like this, open the gate, it's a big wiener dog. That was a big deal. It just didn't scream out, hey, it looked like we're a survey, not, hey, we're a potential false claim investigation. All right, last thing I want to talk about is what everyone in the organization needs to know about contact from the government. You know you're in trouble when either you get a request for multiple medical records or armed agents show up at someone's home. They might show up at the office, but they are more likely to show up at someone's home. And part of the compliance process is having people prepared for that eventuality. Any of these agencies may come darken your door. Just so that you know the acronyms, MFUCU is the Medicaid Fraud Control Units, and they are getting funded in a big way. Medicaid has gotten far more active. In the first 17 years of my practice, I had one Medicaid audit, and in the last 2 years, I've probably been involved in 7 or something like that. The Postal Inspector, Defense Criminal Investigative Service, the Nuclear Regulatory Commission, any of these agencies can conceivably darken your door. And we've already talked about the fact that people need to know ahead of time how to handle this. Even if you prep them, they'll forget it and they'll get scared. We have these little laminated cards on what you need to know if you're contacted by a government agent. We give them out free. If you want them, let me know. Send me an email. We'll send them to you. In fact, everyone gets a CD of this presentation, and as part of along with the CD, we're going to send one of the cards. So if you've never seen one before, you'll see it there. And then if you want more, just let us know, and we'll send them to you. As you want all employees to know that if they're contacted at home, here's what you do, and here's who you call. You can use an outside lawyer for that, but you probably want inside numbers because you want to be able to set up a calling tree, because if one person gets contacted at home, other people are getting contacted at home. So you want to have an emergency plan that allows you to get a hold of all of your employees in a hurry, because if it's Thursday night and they show up at one person's house, you need to act fast. Getting a letter is easier to deal with than most other things, but if you do a letter, I have two requests. One, make sure you keep a physical copy of everything you send. In the era of the electronic medical record, people sometimes think, oh, the record's right there. I'll just, we're going to send them a flash drive with the stuff. I'm not going to worry about it. Make sure you have an exact copy of whatever goes in. And ideally with page numbers on it, because you want to be able to refer to stuff easily and also be able to identify if anything got lost somewhere in the process. Telephone calls are relatively rare. Don't believe they're authentic. So if someone calls you purporting to be from the government, don't ever do anything on the phone in that initial communication. Get their name, find out what they're talking about, and call them back. I'd treat them the same way I would treat a reporter. And for all the reporters on here, I apologize. But basically, when a reporter calls, you want to take time to think about it. You don't want to make rash decisions. Take a breath. And so find out when their deadline is if they're a reporter. If it's an agent, say, who are you calling? Where are you calling from? Take down the information. And then don't call back the number they gave you. Look up in the phone book where they're from and call them there. Twice in my career now, I've had people purport to be government agents when they're not. If someone shows up at the door with a warrant, they get in. And you shouldn't talk to them. You can offer them coffee. You can be friendly. You can get a business card, but don't engage them in any discussion about what actually happens. Get a business card from them and call a lawyer. If they don't have a warrant, they don't get any information. They don't get to walk out with anything else. They might come in with something that's a subpoena. They'll get stuff, but not right away. They may say that they have the right to immediate access to records under the Medicare program. The law defines immediate access as within 24 hours. So unless someone has a search warrant, and I mean a document that says on it the two words, search warrant, nothing should happen until legal counsel gets involved, whether that be in-house or outside counsel. Employees, everyone needs to understand that the agents take the beware of dog sign and replace it with a dog okay sign and say everything's all right, you can talk to me. That's not true. Then the agent uses the most sophisticated technique possible to get attention. They sit there quietly. And people out of fear or confidence will start to talk. The best thing anyone can do is to sit quietly. One mistake that's really easy to make, let's say the lawyer told someone, yes, you could do this. People will instinctively think, I should tell the agent my lawyer told me it was okay. That statement all by itself can constitute a waiver of the attorney-client privilege. The bottom line is you're in a minefield when you're talking to government agents, and no one should be talking to the agent without a lawyer present, ideally their lawyer. Like if they work for an organization, the organization, if you're employed by an organization, the organization will get you a lawyer. They'll pay for it, but that person will be representing you on the nickel of the employer. Take advantage of that. Don't talk to a government agent until you've got that lawyer there. The government investigator will do this. They'll pretend they're the shark in the boat with you. I'm going to tell you, the question is, if you don't talk to the government, they might get mad at you, right? Okay, I'll go back and tell my people that you're staying in the boat, but I warn you, they're not going to like it. The choices available are either jump in the water and have happy sharks, or stay in the boat. Similarly, you can talk to the government agent and make them happy, or you can refuse to talk to them and make them mad. I'd stay in the boat. The bottom line is the rules are complicated and you may have made a mistake without knowing it. So the last slide, it is important for you to understand your rights. Agents can't make anyone talk. They can't get documents without a warrant or a subpoena. They can't get privileged information without a subpoena. And with the subpoena gives you a right to look at it and figure out what's up. And they can't prevent anyone from talking about the interaction. And I lied, there's one more slide. Which are your obligations. As an organization, the organization cannot prevent anyone from talking to the government. People have an absolute right to talk to the government. And so you can't have a hospital policy of no one ever talks to a government agent. But you can have a hospital policy of saying, we encourage you not to talk to government agents. You have the absolute right to do so, but if you choose to, we encourage you to have a lawyer present and we'll pay for that lawyer. You can, and I encourage you to have that policy. Anyone who talks to a government investigator has to tell the truth, and I think it goes without saying, but don't destroy or hide documents. if you think about everyone who's gone to jail and gotten in trouble, the cover-up is almost always worse than the crime. All right, I do have one quick clarification. I think I said earlier that everyone gets a CD. That is not entirely true. The main registrant from every organization gets a CD. So if you're the main registrant, you'll get a CD. So it's kind of one per paying customer. So I don't know if there are any questions on this one because it's not a question-heavy topic. Please fill out the evaluations. Remember that the next webinar on April 11th is going to deal with physician supervision in all kinds of both hospital and clinic settings. And happy Ides of March Eve, everybody.